It's fine. Jeff is yeah, Jeff is.
Yes.
Yeah, that's like hey guys. Good morning, everyone. Great. Thank you all for being here this morning. This is a very important grand rounds, not only because of our prestigious speaker who's here with us to educate us, but this is the first annual visiting professorship in orthopedic trauma named after David Kahler. Many of you in this room don't know Dr. Kahler. He trained quite a large number of our faculty and really was the foundation of the orthopedic trauma service here at UVA. He joined UVA as a fellow, the McHugh Sports and Hand Fellow in 1991. And then he was asked to stay on faculty. And back in those days, there was 25 residents in the program, and there were about 5 faculty. And he was sort of one of the faculty to join in a very small department where all faculty did everything because you were required to at that time. He quickly became the premier fracture surgeon and complex fracture surgeon in our department. And he was the one where all the difficult fractures went to. He was also one of the team physicians for UVA athletics for many years. And he was a tremendous educator. His focus was in computer-assisted orthopedic surgery, and he started the organization, the CHAOS, I guess they call it, Computer-Assisted Orthopedic Surgery in 2004. He was president. He was past president of VOS. He was incredibly involved in developing trauma surgery as we see it today. Well published in his area of trauma, and a tremendous educator, was in the Academy of Distinguished Educators here at UVA. We unfortunately lost him at the young age of 59, 2.5 years ago. He was a tremendous mentor to so many of us, and this lectureship was named in his honor. And this is the first one, and it's sad in many ways, but I'm excited to celebrate Dr. Kahler's memory. We had a wonderful dinner last night with many of the residents and trauma faculty celebrating Dave's memory and remembering all he has contributed to our department. So Dr. Vicki Norwood is here. She was married to Dr. Kahler, so she's here. We have members of his family and her family maybe listening in, although they're on the West Coast, so it's a little early. But we are taping this and we'll be sending it to the Kahler family. So the alumni and Dr. Kahler extended family helped support this lectureship. So I'm very proud that this is the first one we're able to remember Dr. Kahler and all his contributions to our department. So I'm going to now let Dr. Weiss introduce our visiting professor.
Well, it's a real pleasure and honor to welcome my friend and colleague, Dr. Thuan Lee, from currently at Massachusetts General Hospital, to our first Kahler visiting professor. Dr. Lee did his medical school and residency at the University of Minnesota in Minneapolis. He then did his trauma fellowship at Carolinas Medical Center, now doing business as Atrium Health, soon to be renamed something else, I'm sure, with Wake Forest, but at the time, Carolinas Medical Center. And he went back to join some of his mentors back in the St. Paul area of the Twin Cities at Regions Health for about 9 years. He was there till 2015. Then he went to Ohio State University and was instrumental in getting their trauma program kind of tuned up and running, and then transitioned to Massachusetts General not that long ago, 2021, and he's finally gotten settled in as the Chief of Orthopedic Trauma at Massachusetts General. So Dr. Lee has a real passion for educating residents. He and I have been colleagues and worked on a number of education courses through the AO, one of our premier educational organizations, the Orthopedic Trauma Association, where we've run courses and been on faculty together with a lot of courses. And he's also very interested in system improvements. And so he's going to talk to us this morning about some of those things. Dr. James Burgess will be with him next year as he continues his education in orthopedic trauma up at Mass General. So it's a real honor and a privilege to welcome you to our first Kahler.
Thanks, Dave. Appreciate it. Thank you, Dr. Chapa, for the invite, and much appreciated Dr. Norwood and Dr. Kahler for the generosity. And it's certainly a pleasure and a privilege to be the first lecturer for this. So looking forward to it. So far, it's been fun, and looking forward to the rest of the day. We're going to talk on system improvement, the trial, the tribulations, and the triumphs, and give you a little background on actually what ignite this system improvement talk. Actually started back when I was in your shoes over there as a second year. I remember as a second year doing a general orthopedic rotation at a community practice, and one of my senior faculty and mentor came up to me and said, "Tan, how is it that when you're a PGY 1 and 2, you're just so excited, you're jubilant, you're enthusiastic? What is it that happens along the way by the time you're third year or fourth year and achieve that something must happen, that you're not as happy, you're not as excited as you were when you were PGY 1? So I was trying to think, what's he talking about? I mean, what's there not to like? You know, you get to operate on patient and do your dream job. So along the way, as a third, fourth, and fifth year, I started to realize what he's talking about. So when I graduated, I came up to Dr. Ahmed at the graduation. I said, "Dr. Ahmed, I have the answer to your question that you asked me 3 years ago." I said, besides just taking care of patients, but when you're working in the healthcare system and hospital, there are challenges and obstacles that we face that sometimes we're not trained to do that, to manage them. In addition to that, it also, when you're having to work with people that might not have like minds like you do, can be a challenge. But over the years, hopefully you'll see this is my class that we did have a smile on our graduating day here. But it's certainly something that I'll talk about with regards to how to improve the system. So as Dr. Weiss talked about, I started at Minneapolis, St. Paul in my first 9 years. I have to admit, it was tough in the first couple of years, right? We're trained as resident to be really good surgeon, educator, and researcher, but sometimes our residency program may not train you to manage the other issues. Just throwing it out there, radiology or anesthesia or the operating room, some of the issues that may be challenging. So when I became the medical director at Ohio State, that comes with greater responsibility, right? Try to improve the system in many aspects. And so that's when I began to hone my skills and learn a lot from mentors in terms of how to deal with a certain situation. And then finally, I certainly wouldn't be able to handle this year and a half at MGH, which, you know, with the name and, but also at the same time, the culture has been pretty well ingrained. And so, so moving my family from all those area, I'm able to kind of be able to manage it a lot better now than I would if I was doing this in my first year. So that leads us to my objectives is to kind of describe to you the 8 tips to minimize failure and improve outcome, recognize the pitfalls and how to avoid them, understand that's going to be very important. So the rules of engagement when you're collaborating with others, and this may be with your colleague residents or your colleague in your same division across a department and a hospital. And I know it's a cliche, but certainly no I in team. When you're trying to improve a system, you have to work together. As I mentioned, challenges are across, I mean, the entire country, especially with COVID, it became a little bit more challenging, especially with shortage of staff. It has a significant impact on everybody, even down to the patient's care and then certainly trainees. And then if you don't handle it well, you know, it can be challenging. And I noticed that when I get stressed out, I get a little bit more gray hair, and then hopefully it gets less and less. It can be insurmountable at times. You feel like you're the lone wolf. This is actually one of Dr. Badger, which Chelsea knows. She is the chief resident, is now in private practice after doing her joint fellowship at Brigham. She gave me this painting and just because she saw what I did during the residency program for her was not just teach how to be a surgeon, but also teach her how to manage some of the issues that she's going to encounter when she's out in practice. So I didn't realize she's also a great painter as well. We'll talk about sort of effective strategies and do's and don't. I got this painting here by Alan Freeman, a friend of mine, in launching the canoe. It really symbolized so the timing as well as the working together in order to try to accomplish how to improve the system. As traumatologists, we certainly would not be where we are today wasn't for the AO. So the AO is a working group of general surgeon as well as orthopedic surgeon that got together and trying to find a way, how do we fix fracture with internal fixation? So this group met in Switzerland at that hotel that I show you about, and they were like minds trying to figure out how to improve something. And it's important when you have a group that are very like minds, you're more likely to be successful. So taking a page from that, I'll start my 8 tips. The first one is I call it the rule of thirds, and not to be exclusive or anything like that, but I'm cautious when I give this talk. Surround yourself with the game changers. And so try to get people that are very like minds so that they follow your vision and mission of trying to make things better. So they're the one in the green. You know, they're going to be proactive. They come to work excited and trying to see what they can do to make things better. They have the I can't attitude. And then you want to avoid sort of the try to influence the people who are a little bit more negative. You know, where they have the I cannot attitude. And what's worse off is that if they sometimes inhibit you from doing what you want to do, and they actually undermine your mission. So. And so you have to be kind of cautious about that. The middle one, which we'll talk about, is really important. This is where you're going to find your diamonds in the rough. This is where they may be passive or latent, not because they're lazy or don't want to, but it's because they're just inexperienced. And I think with some coaching and fostering and mentorship, they can truly become the game changer that you want them to be. And then hopefully time, you know, I'm still trying to strive for this, right? That you can start to weed out sort of the negativity, and that's how you can start to improve the system. This is actually from Harvard's Business Review, this grid 4x4. I don't know if we can still publish something like this, but certainly the authors looked at how people choose who they work with. They discuss about the benefits and the drawbacks of this phenomena. And so if you're wanting to change the system, you pretty much want the lovable stars, right? And so that kind of correlates with this green with regards to the game-changing agents. You know, these are my two colleagues at Ohio State, the APPs, that were brand new. You know, I like to teach a newbie, teach them and train them the way it should be. And then the search tech, which I'll point the GOAT, the greatest of all time. And so with time, you know, you're going to miss them if you leave or they leave. And so those are people you want to train. So this is where I call the diamond in the rough, right? So sometimes as a new surgeon, you don't get the experience of the best tech or circulator. You always get the newbies. And so take the time to invest in them and train them and foster them, because you really can make a change in them and making it for the better. And what you want to do is avoid the people who are negative that are actually teaching them, because they are often may pull them to the other side of the table. Coming from Boston, you know, he recently retired, maybe not retire, in maybe in about 3 months. But you know, he was a 6th-round draft choice for those of you may not know, right? So they identify him and foster him, and so he, you know, we say they will become the GOAT. Abdi Somo, he's actually a good friend of mine at Ohio State. Now he's actually working here at UVA, but he was I could tell he was a superstar from the get-go. And what we did was, people like to have a dedicated circulate and search tech, right? Do you get that often? Or is it just a joint service? So I kind of make that little nudge there, but actually, slowly with time, you know, we're able to do that. So I often will ask the ortho supervisor, say, give me the newbies, you know, because a lot of them, they also want to be part of a team. So you take the time to train them. Maybe you won't get that 5th case in that week when they're with you, but in the end, it's going to be well worth it. And the other thing is I also hold Abdi accountable too. I said, I will train them. My case may take longer, but do me one favor, please do not take them away from the trauma service once they become good. So that's something that you have to hold them accountable for. And then, like I said, you know, as a mentor, you want to teach your residents. Something I always worry about as an educator. I want Chelsea to know my good habits and avoid the bad habits. And the tendency sometimes our bad habits can show itself. And so this is Andy Campbell, who texted me after his first 3 months in practice. He said, trying to implement your method to the madness. So as he always gets the newbies. And so he took the time to train them. And so he would take this picture to show that he now has a team as well. So tip number 1 was, if you want to be successful in trying to improve a system, really surround yourself with like minds, and it makes things a lot easier. Next one is number 2 is your vision, right? So you're more likely to be successful if what you're trying to accomplish goes along with what your chair wants, what your chief of the division wants, what the hospital mission is. And so it's imperative to know that vision, define what it is. And the biggest one is, if you're going to ask your chair or the hospital for support on something, make sure you follow through on it. So have the discipline to execute that. This is my organization chart that I gave to Dr. Harris when he hired me a year and a half ago, where what I want is also what he wants, was to build a musculoskeletal infection service, researcher, education, clinic. And you can see some of them where I don't have a lead in that. I have 5 traumatologists in my division, so I kind of left them blank because, you know, too much is given, much is expected. And so I kind of left that blank until I can see who are my game changer. And so you can see after, and then the dotted line is what I'm hoping to accomplish. And so you can see that over a year and a half that you're able to fill in your boxes and start to fill in your people who are a game changer for your division. So a busy slide, but it's something that I want to do. Make sure you have a vision and try to execute it. What about trauma call, right? So it's a contentious topic, I think, across the whole institution and country, who should take call, who doesn't have to take call. So being a medical director of trauma, I had to make the call schedule. So that's not fun when I would ask for days that they cannot take call. And so people would give me 29 or 31 days they can't take call. Yeah. So that makes it a little bit more challenging. At the same, so what I used was the Academy and the OTA statement on call that all practicing physicians who's still active should contribute to call somehow, I think to the hospital, to the department, as well as be a role model to the, so I used the guilt trip, right? Be a role model for the residents, you know, so at the same time, I also understand more the senior faculty shouldn't have to take the same load of call as the junior faculty who's trying to build a practice. So we negotiated and were able to develop a graduate type of call schedule where holidays is split evenly, but on weekends and weekdays, the junior faculty would take a more call than the senior one, and it worked out pretty well. Where I don't, when I make the call schedule, it's pretty easy. Tip number 3 is choose your battle. Don't try to pick every battle. It can be exhausting. I remember when there was a bad X-ray, which I'll talk about, where my senior person said, "Thuan, you're the medical director. You got to give a phone call to the radiology department and tell them to change that." And if you do that on every single basis, sooner or later they have caller ID and they know they know who's calling. It's like, oh, it's Dr. Lee again. No, don't pick that up, you know. So be cautious. Try to collect the data. So this is what I did, right? Choose your battle. You know, as I mentioned, you want to get an AP and a lotto, and this is sometimes you get is an oblique view when you truly want a lotto. So what I did was it didn't take long, right? You just collect data for a 1 month period and give them a list of 75 to 100 in terms of where the X-ray order was not executed properly. In addition, that take the time to actually tell them why if I had a good lotto view, or tell them why what it is instead of just kind of giving them a list. The more you invest time in it, the more they're likely to help you out. So I did that, and you know, every department they have quality assurance, right? So just like our orthopedic department do, the radiology department also have quality assurance. So when you give them a list, they have to act on it, and so they actually like the list. They actually created a improvement program for this radiology tech to do a better job, and they actually improved quite tremendously. In addition to that, also I'll talk about the next tip in a little bit is be the first to volunteer. So I would volunteer and go down there and give them talks on, hey, this is when I'm trying to get a oblique view, this is what I'm looking for. Or when I'm trying to get a canale view, this is why this is what I'm looking for. And that helps with the tech to kind of understand what you're trying to do. Gravity stress view. What about dedicated anesthesia team? Is that possible? I mean, you would love to have a dedicated anesthesia team, right? So how many have you had your case canceled because of anesthesia? Yeah. So especially in medically complex patients like the trauma, the hip fractures, right? They're very complex, and sometimes depending on what team you have, they may cancel your case. So I remember early on when I got to the institution, I said, yep, tell the OR team, we're going to get 4 cases done today. And the Ortho Supervisor said, are you sure? Do you know who's in your room today? And so that kind of concerns you. And so what I did for the first 3 months was to kind of get to know all the anesthesiologists and see what they're comfortable with and not. So I would give the director of anesthesia a list. Don't just give them a list of 5, because it's usually the 5 that everyone wants, you know. So give them a list of 10 to 15 that you think are comfortable with the complex patient. And then sometime what they do is they do it for a while, and then they fall back to the same way again. So what I did was, you know, it takes time, but collect the data, you know, have your team do it. And you can see over a 4-month period, you can see that the blue is where they have a different anesthesia in the trauma room that is not part of the list. And so by showing them the data, it's much more powerful than a day by day where you pick up the phone and say, hey, this is a bad day today, you did this, you know. After a while, they just kind of get tired, and when you come walking toward them, they're walking away from you, you know, from afar. So that's not good. So collect the data, and actually I share this with them. It's pretty powerful where you can see here, I had 4 cases in that first slot, and not only I did not have a consistent anesthesia just for that one day, but I had 4 different ones for 4 different cases. And that can be challenging when you're trying to tell the first anesthesiologist that your second and third case may be complex and they're comfortable with it. And only later on is a different person that may change their mind. So collect the data is a lot more powerful and you're able to accomplish what you need to do. And then, as I mentioned before, right, don't complain unless you're the first to volunteer, right? So how many had those bewitching hours at 3 o'clock when you call and for the patient to come down, right? And so transport may, instead of taking half an hour, it's like, where's my patient? It's like 2 hours later, right? So I actually just go upstairs and pick up the patient myself, you know, and so sometimes you have to do that. In addition to that, if they're asking you to join a committee to look at something, do that, especially if you're the one who's bringing up the issue or complaining about it. You get a lot more credibility that way. I'll give you a good example of the weekend first case start. Does your weekend always start at 8 o'clock? Does usually get pushed out 9 o'clock or something, right? So once again, same thing happened here where I evaluated the weekend first start. I took data for a year and a half. We had 202 weekend possible first case during that time frame. And I was trying to look at what are the potential issues that delay getting an 8 o'clock start. And so I showed them this great example where my patient didn't even get down to the pre-op until 8:20, you know, for an 8 o'clock start. And then even though the room was ready at 8:10, the patient didn't get into the operating room until 9:30. So this is just an example. So we collected the data and we found out that 31% of the cases start on time at 8 o'clock, only 31%, especially when you have a full day where you have 4 cases, right? You know, it gets to that 4 o'clock and they want to stop you, right? And it gets pushed on to Sunday and it's perpetual cycle. So this is where you collect the data, kind of show to the hospital and the leadership that starting on time is crucial. And then, and as we get further along, I know it's a busy slide, but there was a disconnect between when the operating room circulator search tech and the anesthesia attending and residents show up. It's at by 7. The CRNA, who is actually always scheduled in the orthopedic trauma room, doesn't come till 8 o'clock. So you can see why our trauma cases didn't start till 9:30. So it's a simple fix, right? You ask the CRNA to come in at 7, maybe not, right? Or the other option is move the orthopedic trauma case till 9 o'clock or 9:30, right? If you don't have expectation, you can't be disappointed, right? So what they did was they asked the anesthesia residents to start the orthopedic case, and then when the CRNA came in, they relieved that. So we're able to actually, after doing this, we actually had over 90% first start by 8 o'clock. So little stuff like that, you show the data, it can make a significant difference. Tip number 5 is look in the mirror and be the first to, you know, hold yourself accountable. I think a lot of time is I see people complain and they're the first one to violate that same issue that they bring up. So I think this is very important, especially when you want credibility. We also had another thing was pretty good. 81% first on-time start during the weekdays. That's pretty good, right? 81% where you start by 7:30. And so what happens if the patient does not get in by 7:30, they would try to attribute it. Is it anesthesia? That's the reason. Is it orthopedic because there's no H&P or consent? Or is it the patient who has to, you know, go, you know, to the bathroom before they go to the OR? And so this is what I call competition breeds excellence. They're able to actually show, you know, each of the attending. So I was fortunate, you know, this is where I look in the mirror, right? Be a good example. So I was second to the neurospine surgeon. I didn't put the name down, but in terms of consecutive start without a delay. And so this is where I would tell the residents, you know, gotta make sure that H&P is done, the consent's done, the labs are done. And so that's important. Amazingly, Dr. X, the anesthesiologist, had 473 consecutive start without a delay. So when this data came out, he or she was the most requested anesthesiologist in the room. So data is very powerful. Tip number 6, I see this happen a lot. I think you probably all will see this, right? Try not to CC on an email their boss right away, right? Try to work with each other. So you work with another resident that you have some issue. Try to work out between them before you start, CCing their program, your program director. Same thing in the division, right? Or in the same department where try not to CC Dr. Sharma right away, right? It creates a distrust and disconnect where try to work with your colleagues first, and then if they're not obligable after several times, then maybe you can bump it up, but try to be cautious about that. This is a good example where CoManagement. I think you guys have CoManagement here, where we're trying to decide the nursing, who should they call, the hospitalist or the orthopedics. So during the daytime, it worked really well, but at night, what happens is that the medicine team said they can't cover at night, as opposed to the orthopedic resident managing the difficult patient. So I worked with the 2 medical directors from the medicine service and negotiate with them. So what I found out from them, instead of getting mad at them or going to their boss and trying to figure out why can't you help at night, I listened to them, and they said, Tom, we're short staffed at night. I mean, we just don't have the bandwidth to do it. And so the negotiation we did was like, okay, at night, they'll call our residents, but if our residents are not comfortable, they should be able to call your attending quickly. And you think that works every time, but sometimes their team are not amenable to that. And so by having this negotiation, it works real well, because I'll be able to go back to Dr. Chase and said, hey, your Dr. X was not really willing last night. So we discussed about this. I mean, it's a give and take. And so he would just work with his colleagues to make sure that the rules of engagement are in play. This is sort of the list of, it works really well during the daytime, where the nurse know who to call when it comes to orthopedic versus the hospitalist. It makes it a lot easier for patients' care. So in summary for that, don't CC or escalate too quickly. Try to work with your counterpart first, right? So respect is the highest within our culture, more so than honor and love. Another tip that I learned from my mentor is if you want to change locally, it's going to be through education. If you want to change globally, it's going to be to research. How many of you had at conferences where you're like, it's the emergency department, they mess up again. They shouldn't have did what they did, and it really creates an animosity when that occurs. And so what we did was we took a proactive approach to it. So I went to the program director of the emergency department, Dr. Kenwa, and said, hey, you have 18 residents a year. Can I start educating them? Can you give me a 4-week rotation? So he did. And we created a curriculum, taking the time to teach them instead of just throwing them on the service and tell them to work like crazy. We actually took the time to educate them. I had the spine surgeon talk, give them a quick talk, the hand surgeon, the joint surgeon on PGI. So the crucial talks that they need to know, and we're able to actually create that. And so you can imagine over a 3-year period that it becomes easier and easier. And the other thing is forward thinking. Many of this will go out in community practice, right? So when we have a competitive at Ohio State or Ohio Health, right? We want to make sure those ED residents who are now attending in a small hospital, where they're going to send it to. They're going to send it back to Ohio State, right? Hopefully, because we took the time to train them. So all of those kind of adds up in the end. Research-wise, infectious disease, it was challenging at times when they don't want to change the protocol. And they can be so sometimes I actually had to publish that the current open fracture protocol doesn't work real well in order to get them to change. And so that's why it took 2 articles to show proof. But in the end, it did change. And like I said, if you want to change globally, you have to do research to make it happen. And then finally, like Dr. Sharma said, Dr. Kahler was quite a mentor to everybody, right? Not just the residents, but to the staff and to everybody in the whole department. So I'm going to talk about finally the last tip is mentorship wise, right? There's really no true definition. It can be informal or formal. It can be short term or long term. But one of the things that I'll highlight is the mentee should initiate the relationship. Sometimes you get a sign, it works fine with schedule, but really pick out your mentor that you want to emulate or you want to get advice on. So mentorship can be, primary, career, life. It can be even peer. So I show this picture because my peer mentor was Dr. Ken Kleiss to my left, right? So he was a sugar and I was the spice. So I learned a lot from him. He said, Tan, why do you keep battling with, this is back in the days when there was plain films. And in order to go to the OR, you have to grab the plain films and bring it to the OR. The radiology department tech don't want to give it out to you, right? Because they get yelled at by their radiologists because there's no films. If it goes to the OR, guess what? It doesn't make it back to the department for them to read it. If they can't read it, they don't get money. And so you sometimes have to put down your credit card, or you sometimes have to put down your license. And so I was a little bit more on the spice side. And so Ken Kleiss at the time, you got to give him sugar, to make it happen. So mentorship can be each other at the same level. Okay. Research-wise, being an academic, this is important. I was fortunate to be trained and did a lot of research with Dr. LaPrade on the posterolateral corner and medial knee anatomy and learning the basic foundation before you start doing clinical research. And then finally doing residency and early career is important to have other mentors like Swinkowski and Peter Cole. That is important when you, the struggle doesn't end once it becomes an attending, right? So you still need to reach out to them often. Dr. Swinkowski comes to the Harvard Resident Journal Club on a quarterly basis. And so now that I moved to Boston, one of my asks of him is, can we meet every time you come? So we go out to dinner, we go seafood or whatever it may be after the journal club so that I can keep picking his brain in terms of how he does things. And certainly the last two, Michael Bossy is sort of my lifelong mentor he was my attending when I was in fellowship, and I would at times really struggle. And for weeks, I'm just, coming home and my wife is like, what's going on? I mean, you've been thinking like this for the last 2 or 3 weeks. Have you called Dr. Bossy yet? And I would say, no, I haven't. And she goes, why have you not? And I said, I haven't because I know what he's going to say. I'm not going to like it, And so your mentor, and also their job is to tell you something you may not like, but is really the truth. And you have to kind of listen to it. And then taking this next job, moving my family and everything, the important thing was want to make sure I'm very fortunate that my next chair is actually also a traumatologist and Dr. Harris. And so part of the interview process, he said, Tan, I'm going to support and mentor you as much or as little as you want. So this leads to where the mentee should initiate the relationship. So in summary, I think that we as orthopedic provider, we have an amazing job. I try not to take it for granted how fortunate we are. There's going to be challenges and obstacles. I mean, moving to 3 different institutions, I realized that across the whole country, the grass is not always greener. But hopefully, when you take an active role in terms of not letting those problems or obstacles define who you are. And then hopefully with the 8 tips that I've given you that may be similar to some of you that have utilized it, or maybe it's a different outlook that hopefully make it a lot better and easier for you to get to the day. So, thank you.
That was a great talk, really interesting. I think those of us, I've been involved with several different institutions. I think most of the faculty, you come through training and maybe you've had other jobs, maybe this is the only job you've had, but you certainly had other environments, and you recognize some of the challenges inherent in working in large organizations with different groups. And perhaps our interests are not all aligned at the same time. And so trying to figure out how to align those interests and get things done. As you mentioned, it's probably a mix of sugar and spice depending on the day. So I'm sure there's some questions.
I have about.
I know Dr. Chopper has some questions. He's getting polite. Normally I'm the one asking questions, but today I'm going to ask 4 questions.
I have.
Go ahead.
That was fantastic, Tom. You know, it's interesting. Your slides. First, I thought man's greatest hospital didn't have any problems, right? You have the same problems that we do, and you made a point that there are common problems across healthcare, probably very common problems across academic health systems, that we all share the same issues and obstacles. You know, you had a slide about aligning your department or division with the university or the health system, and I've had a hard time with that because often the vision of the health system leadership is hard to align because they focus on different areas. They are often looking at revenue with decreasing costs as much as possible. And in a healthcare environment, sometimes you got to spend money to provide patient care. So how have you, I lost all my hair and gained a ton of weight trying to manage these politics, right? The politics make my life miserable, and I'm sure you just mentioned that as well. How do you approach that when if you align, you compromise something?
Yeah. So, you know, I didn't add it on because the length would be too long, but length of stay, right? That's a big topic. And as we have all this meetings, everything is leadership-wise is they want a solution that is quick, but also at the same time doesn't cost as much money. And so that's where the challenge comes in, and it's trying to find a way to compromise where can we, you know, let's just say what we did was essentially realize digging deep, that is having a multidisciplinary where the nurses, the social workers, surgeons investing time to meet in the morning to say what is inhibiting this patient from leaving. Then the next thing is, you know, physical therapy, right? Trying to get them up and moving around twice a day. Trying to get PT just to do it once a day is tough, right? But sometimes when they get them to do something, you have to create a protocol. And then the other one is nursing to get them up out of bed with each meal. Sometimes nursing won't do it because until physical therapy see them. So to answer your question, what I try to be successful is where try to find a solution that you can try to implement and maybe have to use some of the resources that we have right now. But it's a challenge, and I still struggle with that, you know. So I mean, one of the things I think Heller Barrier is talk about trauma recovery, you know, and so that's going to require you know, hiring an APP or somebody to run that clinic, but then you have to ask for another FTE. You know, and so how do you get them to put out the FTE before you can show them the evidence that it does help? So what I'm actually doing right now is trying to ask my APP that I have on right now is, I can get you more help, but can you help me not only see the patient, but write a quick note and bill for the patient so that I can collect the data to show that this past year, our APP did this much of RVU, that it should give you 1 to maybe 1.5 FTE. So sometimes, just like we as a division, if we want Dr. Sharp or Dr. Harris to hire one more traumatologist, instead of just hiring them to come on, sometimes you have to kind of show them that you have the need for it, and you might have to work a little bit harder in order to do that. So I don't know if that helps answer your question.
And the second part of my question. So you mentioned, you know, data is the most powerful way to convince people. And this is a comment on my part, but you have to pressure test the data because the data you're provided has a biased view. So they're going to look at it a certain way. You're going to look at it a certain way. So it's very important that you don't accept the data you receive. Look at it yourself to make your argument, because data can be used in different ways to support different objectives, right? And the one thing that I learned the hard way, because I have a lot of spice too, and I've gotten into a lot of trouble here over the years. But if you're going to question data or question your leaders, you better, one, you need relationships with them, as you mentioned, a very important point. But you need to tell them beforehand, before you start saying the data have put out there is wrong. I mean, I'm in the midst of doing that with our quality data right now, saying that what you're reporting is wrong. But I had to meet with my boss and my dean and so forth to say, we're going to question this, so be prepared for this, and please take this in the right, with the right understanding that we just want to do things better. But you need to have that discussion before you start putting out data that's contrary to what they have.
Yeah. And that leads to like credibility, right? Be the first to volunteer, be the first to do this, and you're right. You have to be really cautious to have that relationship with them, so that they have a trust with you, and try to avoid CCing the boss or whatever it is. Try to work among each other first. But in order for me to gather all this data, I actually utilize the operating room team to do that. And so when they would share with me the data, I would actually look deep into it, because they're going to show you the data that on their side,
Makes them look good.
Yeah, exactly.
We had a similar, I was just reflecting on the fact that we had a thing, you take length of stay, we had, I think, one quality thing on readmissions. So a few years ago, I get this notice, everyone, it's like, we analyzed your readmission rate, it's higher than average. And I said, okay, well, how are you accounting for fractures that we send out that didn't come back? Patients were put in a frame and then go home and come back a week later. I got this sort of blank look like, what do you mean? I said, well, some people we send home and we plan to readmit them. We know we're going to readmit them and they're going to go, because we don't want to keep them in the hospital for a week, because the hospital's full and you want the beds. So we're going to send them home and we're going to bring them back, and then they'll be readmitted, but we know that. Well, like, so you say, well, the data then, how can you trust this data? Speaking of pressure testing, because now I can tell you, I can give you a name of, 10 people of the past year. And so let's take those off the list and redo the data. So it becomes it's an interesting thing when you talk about data, because again, it has to be sort of clean data. And some data is very messy.
And the other thing too is, take the time to have the meeting. Nowadays with Zoom, you don't have to travel to each other, so it's a lot easier. But I always I didn't put on there, but if you have to write more than 5 sentences in an email, you can pick up one and talk to them. Because it doesn't translate well to an email when you're trying to make your point across something. So,
other questions? Just go to the next. Proceed.
I stop sharing.
No, don't stop sharing.
Okay, you should be able to make.
We've been talking about it. So,
yes. All right, so we'll move on to the next one. Is the 3 loss out of orthopedic trauma, preoperative planning, sliding hip screw, and a blade plate. We'll have a little fun with the residents in terms of going through some cases wise. So I'm gonna poll the audience first. It was great when I was able to on the Zoom, so you could actually record and show the audience the outcome of it. So first question, I'll read it to you. Right? How often, how little would you do with regards to preoperative planning? So what describes you best? So you can show your hands, in terms of you plan less than 25% of the time. You plan 25 to 50% of the time. 51 to 75. Or do you always plan? Pretty good. And then next one is 47-year-old female, left hip pain, smokes a pack a day, has this left hip fracture. You can see the AP and lateral. From the residence wise, what would you use for this left hip? How many would do a short and intermediate intramedullary nail? Yeah, James. So we got you next year. Okay. Number 2, long intramedullary nail. Okay. Yeah, good. 3, sliding hip screw. Okay. And then proximal femoral locking plate, a blade plate. Yeah, that's good. And then the last case is a combination of both, right? So on the right side, you have this very comminuted. Oh yeah, perfect.
Good.
Thanks, appreciate it. On the right side, you have this hip fracture, and the left side, you have also a left proximal femur fracture. Okay, so on the right side, how would you fix this? So go ahead. Short and intermediate nail, who would do that? Long intermediate nail. Sliding hip screw. Proximal femoral locking plate. Blade plate. I didn't put it in there, but he's 35. But I'm sure the joint knocking them, they probably want a proximal femoral replacement, right? You know. Then the left side with this hip fracture, same, right? Short, long intermediate nail, long one, okay. Sliding hip screw, proximal femoral locking plate, and blade plate. Who do blade plate? All right, so you know, this is one of those where if all of you said you do a preoperative planning, if all of you would have said you've done a sliding hip screw, and if all of you in the last case would say you do a blade plate, then it'd be great. It'd be the shortest grand round talk I've ever given, you know, because everybody kind of know the answer to everything. But since it was not across the board, so you're gonna have to listen to me for the next 30 minutes or so. So we'll discuss about the importance of preoperative planning. I recognize that a sliding hip screw is still the gold standard for that simple two-part intertrochanteric fracture. Understand that a blade plate can be very useful for both primary and division. And then finally, it will reinforce the AO principles when it comes to simple and complex fracture cases. At the end of this talk, I would submit to you that hopefully you come away with all you need is plan A. And I will discuss more about that. This is something that I did early in my career and still do. I always make a preoperative planning. I give it to the circulating nurse and the surg tech. They put it, they look to it, open it up, what I need, post it up on the desk, so that when there's a turnover, a break, someone's giving a break, right? How many times the main team asks you, Dr. Lee, what do you want for a closure? What do you want for splinting? And all of a sudden, you know, when you're about to close, another team comes in and said, what do you want for closure? You know, so it can be challenging. So by having that, it makes it useful when the new team comes in that they can look at that. This was published in 1998, where they actually looked at 100 trainees and consultant or attending surgeons. How important do they think preoperative planning is? So nearly 100% said they think it's important. When they actually ask them, do you actually truly pre-op plan, right? Only 24% of the trainees say they actually would do a pre-operative plan, and the consultants at 44%. However, when they ask them, should it be undertaken more? So nearly 90% said yes. So the summary on this is that everybody thinks the preoperative planning is important, but in terms of execution, not so much, right? I think the reason why we don't do preoperative planning is I think I'm guilty of this, right? I always do it the same way, you know, trying to tell that to your circulating team when you have a hip fracture and they've seen you do it many different ways, right? It's on my preference card. You know, there's on my 5 traumatologists there. I used to have someone else, but my newbie, Dr. Stenquist, just joined. So someone actually was more savvy and I was able to plug it in that spot. And so he goes, thanks for making me look bigger. It's pretty straightforward. Nothing special is needed. You know, you see what you come into the operating room, it's like, how come the patient's not in the room yet? Well, they realize that, well, what are we supposed to open? What do you want? You know, so by having a preoperative planning can help with that. The preoperative planning has 2 elements. There's a tactical point and there's the logistics. So this is, any of the residents by any chance have this? I think Seth and Dave, you guys still have that? Yeah. It's one of my prized possessions next to the Luttrell textbook. So I still have it in there. I think I just do that on purpose just so I can show it to the residents when they come into my office, you know. But the tactics is where you draw out, you know, especially for the junior residents, like, you know, the anatomy, what you have to be worried about in terms of a dissection. And the logistics is more for maybe senior residents and attending, where you're trying to communicate with the operating room what implants you need, what position, what instrument to make things go a lot smoother. So this is actually, I think this is by my first year in practice. Somebody took a picture of it. I kept it. I would come in, if it's my day to operate, I would take the time to go over every single patient. It only takes about 5 minutes for each patient, but to go over, review the H&P, essentially a dress rehearsal, formate a plan. Early on in my career, it's more tactics, but now as I become more experienced, it becomes more logistics. And so this is goes to show I wasn't quite a good resident when I was the third year. This is really a dinosaur, right? A dynamic contour screw. Anybody still seen it, done it? Right, so that's really out of date. And so the attending was allow me to execute what I planned. And so you can see that I have evolved quite a bit over time of being a traumatologist, where now we know that holes in the plate are opportunity to put a screw in it, but does not mandate a screw in every hole. So, so that's I kept that preoperative planning and the X-ray of it. This is what I do now, more logistic in terms of what reduction set I need them to open. And they always ask the same question, right? You know, what table do you want? What do you want the C-arm coming from? Do you want the bone form? What type of implant? So I find that by having this, even down to the sutures and the splinting, it makes it really easy. And this is what I always teach the residents. Always have a 5% fear that even in simple ankle fracture that you can go bad. So one of the pet peeves I have is when a resident fellow come in and said, "Oh, you got a chip shot ankle today," you know, like, "Oh, he just jinxed me," you know. So it's important to always plan, even for the simple cases. As I mentioned, practice become more logistic as you gain more experience. So that's such a way that hopefully by doing this plan, you can get that 5th case in by 5. You know, otherwise, if you don't plan and they're not sure what to open, then you can only maybe get 3 to 4 cases done. So this is my one slide where, you know, you never know, right? You can never be too prepared when things can go pretty bad. So it's important to really plan ahead. The operating room loves it, right? They love the communication, so they know what to open and get things ready for you. And this is actually, I want to actually start looking at this, where can it really save time and staffing, right? Especially with shortage and everything. So the less you open, the less they need to take down, and the less that they actually have to flash for the next case the rest of the day. And so it can be challenging to try to figure out from the data if you actually save money by doing that. And I would submit to you that decrease in infection, right? So we're not to the point of joint surgery where once you open a capsule, there's no room traffic, right? But by me making the preoperative planning in our operating room, the circulator doesn't have to leave the room as much, and there's less room traffic because all the instrument and equipment that you need is already in the room. MRB, this is something, James, you were here next year. We have an MFB, right? Maximal residence and maximal fellow benefit. With regards to when we're training them, it's all about them. And so as an attending, you want to train them, mentor them, inspire them, and lay down the foundation. When I wrote this article, it was important because I realized that when I'm Chelsea, I pick on Chelsea if she's still here, where I'm trying to tell her, you know, why can't you be like me? This is how I was trained by Bossy, you know, and they start to get sick and tired of hearing you know, that you have to walk 1 mile to the operating room and all those things. So you can still lay down the characteristics that you think makes a great resident that was taught by you by your previous mentor, but also realize that the trainee nowadays have a different style of learning. And so you have to evolve as a attending and a service. So this is something that I started. You can see on the right side, all our residents of different level, and then the attending down there. But they don't do. I don't expect them to do a pre-operative planning because there's no, tracing paper and there's no plain X-ray. So what I do have them do in the morning is discuss about every case. So we'll start with the first or second year for simple cases, and they would go over the tactics. And then to more complex case, the chief would discuss what they're going to do. And then this is where I actually teach the chief, so we have 3 plateau on today. Have you thought about making sure that the company we're using has 3 sets of plates that your attending is using? So that comes to logistics, to make the overall goals a lot smoother. By doing this, you really stimulate discussion, but at the same time, as attending, there's a time to be wrong. And so you should feel, be good to them in terms of not chastise them, right? So if you start to chastise them, then they're not going to speak up. So it's something that we try to foster. And then value transference between generation is very challenging, but I think the solution is evolve your method of teaching because the trainee are learning a different style now. They're more visual learner, and so try to do that and optimize the education and the report. So tracks and pint is something that we do at the end of every rotation, where we go to Harvard Garden, which is a bar across the street from MGH, where at the end of the rotation, we would get all the residents to go out with the attending. And we would invite all the residents that are at MGH, whether they be on joints, sports, other specialty, that they're welcome to as well. And it's nice, even though I'm the division chief, but I always make sure I invite my chair because he has to pay for it, so that's important. That's not the mid chair, it's right there. So, and ultimately, a good pre-op planning will benefit the patient because everybody's on the same page. So here's a quick summary of that pre-operative planning. You can see this really symbolizes if you don't plan in terms of what you're going to do, it doesn't go too well, right? So where the garage is where it should not be, right? All right, so question number 2 that we had before, right? I think many people say they would do a short intramedullary nail, right? So ask and you shall receive. So this outside position is this short intramedullary nail. I don't know if you can see back there, it's kind of dark. So what do you think about that? Any thoughts? Is there any way we can dim? Yeah, so you must be talking about this, right? So when you see a cerclage wire, right? Something went wrong, right? So what do you think? What do you think might have happened?
There was a mismatch.
Yeah, right. So the surgeons didn't plan and realized that. You sure you want to do a fellowship next year? I think you can just go on practice, right? So the canal. Good, that's good. We'll be nice at the morning conference at MFP, MRB, So you're right, the canal is 8 millimeter. And as you know, when you're doing a short nail, you just wean the proximal end only, right? You don't wean the canal. And sorry about the lighting here, but you can see the fracture. And then so they try to solve that with a cerclage wire, right? So whenever you have a complication, you have to kind of look at the AO principle, right? So the patient, so what do you think here, right? I would submit to you that you all know the 4 AO principle, right? So when something is not right, there's a complication, I would submit to you that if not all 4 principles are violated, and by understanding what it is, it helps you to salvage it. So anatomic reduction, by that, right? It looks like this big gap at the inner trunk portion, right? Stable fixation. Yeah, right. Not the cerclage wire might not be the way with regards to the shaft, right? Preservation of soft tissue. Maybe lost a little bit, right? And then early range of motion, weight bearing is tolerated. So they make the patient non-weight bearing because they were concerned about the shaft, right? And so there's a lot of influencing factors to an outcome. So there are things that you can control, and there are things that you cannot control. Certainly the things that you can control is going to be the quality reduction, the implant selection that you choose based on the fracture pattern that you have, and the implant placement. So this is where I make the argument that a sliding hip screw is a lost art, and I'll tell you why. For this simple 2-part fracture, you've seen this classification pretty well, right? There's no discussion, right? The bottom one, the A3, that's your reverse oblique. your transverse and your subtropic extension, where Head of Cabbage show that a sliding hip screw is not the ideal implant. A fixed angle or an inch measure device would be ideal. The top one is stable two-part, right? So you can nail that, but I think the sliding hip screw, I'll make an argument that's probably the right implant. And then the question is, what do you do with A2, right? So I think some would say the left upper side, you can use both a sliding hip screw and a nail, whereas the bottom right side, probably a fixed angle, a nail would probably be ideal. So they actually looked at this in 2008, where Jeff England looked at the ABOS when he took the board. They started to realize, why is there a trend to where the people who submit the case that they do a more intramedullary nail than they actually do a sliding hip screw. So you can see the red is in a sliding hip screw. And as you see, 2006, there was a lot more intramedullary nail than sliding hip screw. And they noticed that the changes occurred despite the lack of evidence. At that time, they thought that maybe because based on RVU. Intramedullary nail had, I think, 3 to 4 more RVU than a sliding hip screw. So they thought maybe that come into play. So what did they do? They made it even, so that they hopefully maybe remove that elements away from it. And further randomized control trial looked at it to see that in stable intertrope fracture, they said that the nail did not provide any more clear outcome benefit than the sliding hip screw. And then our other meta-analysis also said the same. But when they look at cost, so they actually showed that sliding hip screw was a lot cheaper than the intramedullary nail. And then, it just became more and more literature looking at it. Why do you think we're doing more intramedullary nail versus sliding hip screw? And so Dr. Mary Forte here looked at it and said that it was likely because the training program were doing more nail and teaching the residents. In addition to that, the early career surgeons were also doing more nail. So you can see the perpetual cycle that kind of keeps going with regards to teaching them doing nail versus sliding hip screw. So I would say a lot of times this is what I call the MRB. When the residents to show that case, I would ask them if they've done any sliding hip screw. And if they say no, or they say maybe 1 or 2, then that day we'll be doing a sliding hip screw. I think that's important because you need to know how to use the sliding hip screw, because there are times later on that you may need to use that implant. Go back to that case. 1 year later, presented to myself with this persistent left hip pain. Did a workup on the patient to see if that shaft has healed. So how do you want to salvage this? Any thoughts? Yeah, salvage, right? So yeah, if you're just concerned about where's still stress rises. So did the workup, like you said, right? Make sure it's not infected. I feel that it was sufficiently almost healed, right? On that, and that way you can determine what to do. And so plan and execute. And so this is my preoperative planning here for that case. And I went back to what should have been done the first time, right? You can do a blade plate, but I think with the angle of the fracture site, the sliding hip screw, I felt that was more in line with the fracture pattern, so that the collapse can occur in this situation, and then and bone graft, and then use a 8-hole side plate instead of a 4-hole to make sure that you bypass that area that could be a stress riser. So something like this, where I said, right, a simple fracture, if you don't preoperative plan, realizing that the mismatch of the nail and your isthmus fit can quickly gone to this patient who lost a year of life because of disability and everything. So 6 months later, she went on to heal. As I mentioned before, in the end, hopefully you think that all you need is plan A. So sometimes the residents would come to me, or the fellow would say, Dr. Lee, I'm excited for this next case. I've got plan A, plan B, and plan C. And I said, you didn't really think much about along with that case issue, because he goes, how do you know that? I said, well, if you really think about plan B and C thoroughly, it doesn't really work, and we don't have that implant, whatever it may be. And then they try to keep going, like, well, what if your plan A doesn't work? What are you going to do? And then this is when I submit to them, well, have you thought that plan A doesn't work? It's not the right plan. It's because you didn't execute it properly. And so that's something that I try to hop on them. So Captain Mark Fleming, who's my new partner, retired. He's an aviator, a pilot, just like Dr. Weiss, right? So he, at the morning conference, said, Thuan, I disagree with you. I'm a pilot. If I don't have plan B and C, I would not be here today. So there's two ways of different ways of looking at things, where sometimes you want to have plan B and C so that you can bail yourself out. So what do you think about this fracture? Nail, right? That's by consensus, right? Do a nail. So what are your thoughts on that? So as I mentioned, right? Nail was the right implant, but did it get executed properly, right? So anatomic reduction, has it been violated? Yeah, right. It looks like it's embarrassed, right? Stable fixation. Maybe just one proximal inner locking screw and just one distal may not be sufficient, right? And then that little unicortical plate, right? Preservation of soft tissue. Right? What's the whole point of intramedullary nail? Is it relative stability or absolute stability? Relative, right? So you don't open the envelope right there, right? So by them making an incision to put the plate on, right? So what do you think the sequence, if you were to predict what happened during surgery on this one? Yeah. Yeah.
It might be so
Yeah.
Put the nail in the live, we had a problem.
Yeah. So they probably attempt to close, right? And that nail is actually a piriformis nail. So do you guys still do piriformis? Yeah, it's awesome, right? And so they did a trochanteric starting point, right? So the problem is that when you start too lateral, you have a tendency to cause the proximal segment to fall into varus. And so when they saw that, then, because I read the op note, right? And then they opened it up to try to put a plate on to try to correct the varus. And it looked great intraoperatively, right? But when the patient walked on it, it moved around a week later, it started to pull out. So this is where you start to think of salvage procedure wise. You plan, just kind of move along, right? This is where I say break out the chisel and a tuning fork. I think this is a lost art. This is why I try to tell the residents, right? On your pediatric rotation, that's where you really learn to do blade plate and try to make sure that you take the time to learn from your pediatric surgeon to use a blade plate, because there are times when it may be very beneficial, especially a salvage procedure like this. And then you can see that open it up and use the blade plate as a salvage procedure is beneficial to correct the anatomic reduction, right? Get stable fixation, soft tissue preservation. You have to do a big dissection, but you can still kind of bridge that area, and then they can do early range of motion and start to mobilize, right? So another case here, 58-year-old with left hip pain, has this subtroch fracture, right? Nail, probably, right? What do you think? Are you afraid to do a nail now? So they attempted to do a nail, and unfortunately, it fell into varus. And so they didn't like it, and so they used this proximal femoral locking plate. Anybody still using the femoral proximal locking plate? It's sort of the in vogue for a while, right? When they start to realize that it's not the panacea, the implant or the salvage procedure of our implant, right? Because it's very unforgiving. So you have to have an anatomic reduction, and you have to make sure all those screws are into your neck and head are perfect. Otherwise, there was an increased failure rate. So 6 months later, still had pain and a non-union. And you see a lot of you with a male union there, okay? So that the usual, look at the principle, see what's been violated, anatomic reduction, right? Still, on a lot of you, is not reduced. Not enough stable fixation. And then they certainly were non-weight bearing for a while because they didn't trust their implant. So salvage procedure, right? So you start to do a workup. I feel that start to realize what can you do now, and this is where you really need to do a preoperative plan, right? And so this is when I think the transition occurred when they went to electronic X-ray, but they still had one that could print out the X-ray for me. So they were able to print out the X-ray for me, and I grabbed my my preoperative planning and draw it out to plan my surgery. So I don't think they print out X-ray anymore, but it's nice when they did that. But this is where hopefully with the computer assisted with preoperative planning, you guys do that with joints, right? That's going to be really helpful to plan your surgery. And so we essentially executed that surgery and then be able to restore the anatomy and get the fracture to go on to heal. So just to emphasize that the importance that even as experienced as you become, you still have to fall back to your preoperative planning so that you don't repeat history. And then you can see I evolve a little bit, right? And they put a screw in every single hole, so that's important to understand and not violate the principle. Now we'll finish off with this third and fourth case. What do you think on the right side? So this is where I think having a 3D is very helpful, right? And so this is where you can see the left side is a little bit more straightforward, right? I'm cautious, I said straightforward, right? Reverse oblique, whereas the right side is very comminuted, essentially a basal cervical or femoral neck fracture, right? So this is where when you have sort of combination, you start to think back, okay, if all I had was just the femoral neck fracture in the 35-year-old, what would be the implant there, James? Yeah, sliding hip screw, right? And so now you add the elements of the graded choke. If all you had is a graded choke, what would you do? Yeah.
You could add it.
Yes. Yeah, like
something hook plate.
Hook plate or something on top of it. Yep. Yeah. So that's how I kind of think about it. Take each in its own, and then now the question is, if you combine them together, the implant you utilize just worked out perfectly, right? So that's just like in a polytrauma patient, right? I love the polytrauma because I know if I'm doing damage control, I'm coming in for maybe an hour and a half, then I'm going home. So because do what you can and follow the principle, and often that's when you do a lot better than trying to overthink it. So we, like I said, use a sliding hip screw and then try to piece all those pieces together. So the 3D was helpful to know where those pieces are, but you're right, or anytime you're concerned about the proximal end where the shaft can needleize, then you have to put on a trochanteric stabilization plate. And then the left side did a primary with regards to blade plates, just go to show that, that you don't have to always use a blade plate as a salvage procedure. You can actually use that as a primary implant. So a year later, went on to heal. So in summary, having a good preoperative planning has many benefits. Sliding hip screw is still the gold standard. I think that even though it's becoming a lost art, but I think it's important that we still are trained in it. Blade plate can be not just as a salvage procedure, but also a primary procedure for a certain fracture pattern. And then really, hone on the AO principle, right? Know it, because I think a lot of times so this is one of the best I make to the residents, and I still have not paid up dinner yet. I said, when there's a complication, whether it be mine or anyone else, right? If you can find a case that had a complication where there was no violation of the AO principle in the fracture, I will buy you dinner. So, and after 16 years, I still have not bought anybody dinner yet. So what do you think the one that I catch him on? It's tough to see. You can't see it on X-ray. Soft tissue. That's very important. Thank you.
Questions on that? Sometimes I think I would be in the Mark Fleming camp on the ABC plan. I talk a lot about having a plan A, B, C, D, and E. And again, maybe it's the pilot thing. Maybe it's assuming that whatever implants I have for plan A are going to get roughed on the floor, and that's the only set we have. And so you sort of have to have a plan B because it's like. But I also think I think when you talk about preoperative planning, you want to think about, and I think you showed some nice options about trying to be thoughtful in how you plan, because there's different ways to solve problems. So you see something that you could use a nail on, or you could use a plate on, and you might choose to do it for different reasons. Maybe it's the patient's stability. Maybe it's the fact that they've got an 8mm canal, and so a fracture that you'd love to nail is actually going to turn into a very hard nail or a very easy plate. And so we talk about this sometimes, I think, in the distal femur fractures, where it's like, oh, I put a nail in that. It's like, well, it's going to be a hard nail or it's a very easy plate. But if you know how to do both of them, at least you have that option, and you can, and then if one's not working, you know how to bail to the next one, because sometimes you'll see, sometimes violations of principle, sometimes things just don't work out like you think. You made some assumptions, and
yeah, no, I agree. That, sometimes when I'm not sure, because I really want to do a sliding hip screw, but I would say open the sliding hip screw, but have available the intramedullary device, because if I see the lower cortex is very thin, then you want to do what's best for the patient, right? Patient's care overrides MRB, right? Maximum resonance benefit, to get them a sliding hip screw, right? So by doing that preoperative planning, and you don't have to like, oh, I gotta wait an hour to bring that intramedullary nail implant up. So that's where it's helpful. So when I do say that, so you do have plan B. So I think it's important. The other thing is, at our morning conference, it's helpful is seeing other ways of doing things. So we always have a hand surgeon that's on either come to a morning conference and a foot and ankle. And so it's great to hear when we do distal radius, how the traumatologist does it and how the hand surgeon does it. Same thing with the ankle. At Ohio State, when you have that posterior mount, right? As a traumatologist, you want to open it up, right? And so the foot and ankle is actually I would get so assisted to fix that posterior mount, And so I started to realize that when my colleague wants those fracture, they would say things that I cannot do, so they can get that case. They're like, oh, God, that distal radius, that's a bonus. And they start getting really elaborate with the biomechanic and all that stuff. I said, Abby, do you want the case? Can you just take it?
questions.
Hey, this is Ted Schuler in Roanoke. I really enjoyed the lectures. I'm a traumatologist here, and I really appreciate the revisiting of the blade plate. I don't do very many anymore. I've been in practice close to 30 years. One technique tip I would throw out that you might value is if you take the triangle guide, if you turn the triple guide upside down, if you take off the 7/0 cannulated set, if you use the 4/5/2/0 guide, that will fit in the outer holes. Then you can put your guide wires down and you can set your flexion extension. You can measure the length of your blade. And then if you drill over that, you can squeeze those together. And after you cut your slot for your seating chisel, you can use that as a runner to help put your seating chisel in. Makes that a little easier. And I'll do that because I don't do very many anymore. So it just makes it technically easier when you do something that's kind of uncommon.
Yeah, that's a great tip. I think that's part of why it's getting a lot of it, because it's very unforgiving, so you don't have the ability to do that. So that's why a certain company will have a cannulated system where it allows you to do the chisel of the into the neck and head with a cannulated system. But those are good tips. I definitely used some of the things that you said that makes it easier, even though I do a lot of it, but still it's unforgiving. So.
One thing that came up too when we were looking at the proximal femoral locking plate, because we were part of that study that looked at the failure rates with that, is that we don't teach it. Like none of the courses teach how to use a proximal femoral locking plate, and so people don't get exposure to it except randomly. Bleed plate, I think a lot of it we don't teach it very much, and so if you're not getting that regular exposure to it, you have to choose to do something that's unforgiving.
Yeah.
If you're not.
I think it's important to realize that this sort of like it is not the savior of everything. You still have to get an anatomic reduction. I mean, I think early on, I think surgeons have tendency to just slap it on. I think that would just take care of it, but that's where things go bad. You know?
Dr. Sweat.
But understand talk. Look at the delayed union or non-unions. So you rule out an infection, you get a better reduction, you choose the correct implant. So next step, we'll think about biology. So either allograft or autograft or BMPs. So what's the current status? So what do you use if you see those?
Yeah, so in the primary, I don't use anything unless there's like an open fracture, a significant bone loss where I worry about filling something in there, but I wouldn't do it right away because of infection. But in revision, I would use bone substitute, and I try to look at more. Am I trying to get osteoconductive, which is allograft, or osteoinductive, which is different type of bone substitute? Am I going for osteogenesis, which then I would need a BMP. So my go-to is, if I can, it's the iliac crest because it has all three. So that's how I look at it. What am I trying to get? Conductive, conductive, genesis. So to answer your question, if I can, I would go with iliac crest bone graft. The time I don't use iliac crest is if they're osteoporotic or out there where I'm concerned that I can't get a good quality bone graft, and I'll use substitute.
If the principals should never have to. All right, great.
Thank you. Appreciate it.
Thanks for coming down.
We have a few gifts for you. So, one, I'm tired of Jim Burgess wearing Mass General in the OR. I wear around. A certificate commemorating our first Kahler lectureship, UVA Ortho Center T-shirt, all gifts for you. Thank you for being here, and really remarkable talk. And I know Dr. Kahler would be very proud that we have this lectureship, started this, and of course we all miss him dearly, but this is a great way to remember him. So thank you, Katie. Thank you. Thank you.
Thank you.